time, surely.
Next time. Thank you, sir. Thank you.
So, sir, Dr. Deepak, are you there? To introduce
Yes.
the next speaker.
Dr. V. Mohan recorded lecture. Sir is
Okay, sir.
not able
Yes.
to come live. So he's.
Sir, so the next lecture is Precision Care in Diabetes. It is being delivered by none other than Dr. V. Mohan, who needs no introduction. He is Chairman and Chief Diabetology at Mohan's Diabetes Specialty Center at Chennai in South India, which is an IDF center of excellence in diabetes care. Dr. Mohan oversees chain of 50 diabetes centers across India, across 8 states in India, and have over 5,60,000 registered diabetes patients in his centers. He is also president and director of Madras Diabetes Research Foundation, which is Asia's largest standalone diabetes research center. His main research interests are epidemiology of diabetes and its complications, genomics of diabetes, including monogenic diabetes and type 1 diabetes, fibroproteinous pancreatic diabetes, and Christian diabetes. So, I hand over the mic to the organizers for the recorded lecture of Dr. V. Mohan.
Hello, everyone. It's a great pleasure for me to participate in this conference and to give you a talk on precision care in diabetes. I'll now present my slides. I'd like to start by expressing my heartfelt thanks to my very good friend, Dr. Vanshi Sabu, who is the organizing chairman of DiaCare Con 2022. It's a very prestigious conference and I'm very humbled to present in this meeting. The topic of my presentation is precision care in diabetes. I have no conflict of interest to declare. All the funding comes from government agencies, either from ICMR or from the National Institute of Health Research or the NIHR in the UK. The subject of precision medicine is rapidly developing, and I'm very happy to say that the, the American Diabetic Association and the European Association Study of Diabetes has brought out a precision medicine in diabetes initiative. And in this initiative, I'm very happy that they have thought of including a representation from India and from China. So Professor Linong Ji from China and myself from India have been included in this expert group to report on precision medicine in diabetes. Now, talking about precision medicine in diabetes or precision diabetes, I would like to split it into two. The polygenic forms of diabetes, where both type 2 diabetes and type 1 diabetes are there, but I'm not going to talk about type 1 diabetes in this meeting. So with regard to type 2 diabetes, I'll have the first part of my talk and then spend most of the time on monogenic diabetes, focusing on maturity onset diabetes of the young and neonatal diabetes. The field of precision medicine and type 2 diabetes really took off after this seminal paper from Leaf Group and colleagues from Sweden. Using machine learning and a data-driven cluster analysis and 6 variables, Leaf Group and colleagues identified that there are 5 subtypes of diabetes, of which I would submit that the first one, the severe autoimmune diabetes or SAID, is actually a variety of type 1 diabetes because GAD antibodies are positive. This is not truly speaking type 2 diabetes. However, if you take type 2 diabetes itself in adults, there are 4 subtypes identified by them. The first is a severe insulin deficient diabetes, which occurs in young people, thin people. They have insulin deficiency as a main defect. The second one is opposite, where you have severe insulin resistant diabetes. They call it as SIRD. The third variety is mild obesity-related diabetes, where you have obesity, but there's no insulin resistance, which we don't see very commonly in India. And I'll come to that. The last is the age-related one, the mild age-related diabetes or MARD. When this paper was published, there was interest all over the world to see whether the same subgroups are present in all populations. So the question we asked is, can this be applied to Indians? Not just because India also has to do it, but because type 2 diabetes in Indians is very different from what is reported in the white Caucasian population, European of European ancestry. For example, the age at onset of type 2 diabetes is much lower in Indians, we have a lower BMI threshold. So you don't have to be very obese to get type 2 diabetes. In fact, you get even thin diabetes. I'll come to that. There's a very high degree of insulin resistance and a very prominent reduction in the beta cell function, which occurs very rapidly, so that pre-diabetes to diabetes transition occurs much more faster in our population. One of the most characteristic features of the Indian type 2 diabetes is a very low HDL concentration. The good cholesterol is very low in our population, perhaps lowest in the whole world. And the triglycerides are also very high. There are a number of other features. For lack of time, I will not go into those. So this is a collaborative study between the Madras Diabetes Research Foundation, MDRF in Chennai, and the University of Dundee in Scotland, and it's called as INSPIRED project. INSPIRED stands for India-Scotland Partnership for Precision Medicine in Diabetes. This paper was published in 2020 in BMJ Open Diabetes, and it's called Novel Subgroups of Type 2 Diabetes and their Association with Microvascular Complications in Asian Indians, a data-driven cluster analysis. Where did the study participants come from? Initially, in the first part of the study, we took all the participants from our own electronic records. As you know, we have centers all over the country. So we took patients from all over the country following the same criteria that Leaf Group and colleagues had used, that is newly diagnosed type 2 patients. But we had very large numbers as compared to their 8,000 patients. We had almost 20,000 people who were included in this study. We also did validation using the INDIAB study. The INDIAB study, as you know, is a representative study of the whole country. Every state in the country has been studied. And there, we also used for validation the ICMR INDIAB data to see whether we are getting the same clusters in the clinic as well as in the population. And when we did that, we used only 6 variables: age, BMI, waist, HbA1c, HDL cholesterol, and triglycerides. Now, these are the 4 subtypes that we identified in our population, both in the clinic population as well as in the INDIAB India population, which is representative of India. The first variety is similar to what the Scandinavian group had described, the severe insulin deficient diabetes. These are thin people, young people, they have less of insulin, very little insulin resistance. The opposite is the insulin resistant obese diabetic. But this IROD, or insulin resistant obese diabetic, is slightly different from the SIRD, which they have described. We have described it in the literature. The third variety, what they had described was MOD, or mild obesity diabetes. We didn't find that type of diabetes. Instead, we had a new group of combined insulin resistant and deficient diabetes, CIRDD. And what is very interesting is that this particular group is unique to India and to South Asia, and they had the lowest HDL cholesterol and the highest triglyceride among all the 4 groups, and I'll show you that. And the last is the mild age-related diabetes, or the MARD. Now again, in Scandinavia, when you say age-related, it's after 60, 65. For us, age-related is 50 years or 55 years. So it's, again, it is quite different from what Scandinavia had reported. You may ask, what is the clinical relevance of this clustering? It has been shown by the Scandinavian group, and we also confirm that the SID variety, the insulin deficient variety, is more prone to retinopathy and not so much prone to nephropathy. On the other hand, if you look at the IROD variety, the insulin resistant obese diabetic, they are more prone to kidney disease or diabetic kidney disease or nephropathy. We are able to confirm that. But there is one additional point which, if you see in our series, you remember this variety called CIRDD, the combined insulin deficient and resistant variety. Because they have both the defects, not surprisingly, they are more prone to both retinopathy as well as to kidney disease. So this is a very interesting finding. One more point that we saw was how much time did they take, the various groups, to get to the HbA1c of 7%. As one can imagine, the mild age-related diabetes being very mild, we were able to get maximum number of people into HbA1c less than 7%. Whereas the blue, showing the severe insulin deficient variety, it was very difficult to get them under control. Remember, it's a retrospective study, so everybody is treated in the same way, whether you're thin or old or fat, everybody is given metformin first. And therefore, this group did not respond as well as the other groups. We have now developed a software called as the Diana software, Diabetes Novel Subgroup Assessment, using just the clinical parameters, we just put it into the computer, the software will tell you, the app will tell you that this particular individual has SID variety, that the risk of developing retinopathy and nephropathy is also given, and it even suggests which medicines may be suitable for this particular patient. To our knowledge, it's the first time that such an app has been developed, and this takes precision medicine to the next level. I'm happy to inform you that this clustering has now been replicated in South Asians in the UK, in Pakistanis and Bangladeshis. This paper in PLOS Medicine, just published a few weeks ago, confirms that the CIRDD variety, which we described, the combined insulin deficient and resistant and deficient variety, is present in the Pakistanis and the Bangladeshis in the UK. And they specifically say we are able to reproduce previously described diabetes subgroups, and they quote a paper. So this seems to be a true South Asian subtype of diabetes. Having dealt with type 2 diabetes, let me now move on to the monogenic forms of diabetes. I'll first take up maturity onset diabetes of the young. Now, MODY is a type of diabetes that was described in the 1970s, but it's only 1990s that the genetics was discovered. Soon, almost 14 different types of MODY were described, and all the clinical features are given here. I won't go into all these details, but many of the MODY subtypes respond better to tablets, to sulfonylureas, than they do to insulin. And we have had several publications on MODY 3, MODY 1, MODY 2, MODY 5, etc. And here are two more reviews on MODY that we have published. But you may ask, as a clinician, why should we bother about MODY? Why don't we just give some tablet and be done with it? I'll show you an illustrative case which will be very revealing to you. A 16-year-old girl came to me many years ago, over 20 years ago. She was thin and she had HbA1c of 10%. And she had met an endocrinologist who told her this is type 1 diabetes and you need lifelong insulin, and 3 times insulin was given. She came to us for a second opinion. The first thing that we saw when we took her family history, this is a proband. We saw that her mother had diabetes, her aunts had diabetes, all these shown in red, and one of the aunt's sons also had diabetes. So there's a lot of diabetes in the mother's family. Now you can see there's a 3-generation transmission of diabetes in this family, probably even 4 generation, which is typical of MODY. So what we did was, we did the next step of measuring her insulin level. We found the C-peptide is very good. We then looked to rule out type 1 diabetes. GAD antibodies and zinc transporter came negative. Because of 3-generation transmission, we did the MODY genetic testing. And as you can see, the star shows that they have MODY, MODY 3 in this case. So the mother had, the daughter had, and then all the people who had diabetes in the family had. By this time, her younger sister also developed diabetes, and we tested for her. She also had MODY 3. So you can see this is a whole family of MODY 3. On the father's side, there's no diabetes at all. So it is very easy. Now we took her off insulin, started her on glibenclamide, sulfonylurea. Blood sugars came down very well, and she and her sister are still responding to sulfonylurea after several years. And this is how a classical example of precision diabetes, and how from the genomic lab, we were able to use the results of our genetic studies to change the treatment and to take this girl off insulin. I'm happy to share with you that this girl came to see me recently after more than 20 years, and she's very happy that we were able to make the right diagnosis for her and take her off the insulin injections. Now let me pass on to the last part of my talk, which is on neonatal diabetes, defined as diabetes below 6 months of age. Now, neonatal diabetes is of 2 types. The transient variety, which occurs before 6 months of age, but then before the first birthday, it goes away. And then we have the permanent neonatal diabetes, where it occurs before 6 months, but is permanent. Now, let me again show you a case study. This is a 3-month-old female baby from Calcutta. She was diagnosed to have diabetes 2 weeks after she was born, and she was started on insulin injections. But even with 3 times insulin, 4 times injections given per day, her blood sugars remained at 300 and 400, and therefore she is referred to our centers. Now, it's a rule now that anybody below 6 months of age has to undergo genetic testing, because you may have neonatal diabetes. So we sent this girl for genetic testing, and we found a mutation in the KCNJ11, which is shown here. Now, children with this particular mutation can stop insulin and be changed to sulfonylurea. So what we did was gradually we increased the dose of the sulfonylurea, shown here in green, and shown in red is the insulin dose. Insulin dose came down, and in blue is the blood sugars. You can see after starting the sulfonylurea only, the blood sugars have become normal, whereas with insulin, it was not getting under control. So by day 5, the insulin is completely stopped. Today it's 8 years since this child came to us, and she's still responding to sulfonylureas. And this, of course, makes very big news, because it's almost like a miracle if you're able to take a child off insulin and treat them with tablets. We have had several reports on neonatal diabetes and monogenic syndromic forms of diabetes. This is the first report on 33 cases that we published. Subsequently, we have much larger series. But what you can see here is if you have the KCNJ11 mutation or the ABCC8 mutation, these are the shown here are the A1C levels when insulin was given. And on the right here is the A1C levels when sulfonylurea was given. You can see from 11 to 7, 10 to 7, from 16 to 6, dramatic reductions in the A1C because the child responds better to sulfonylureas. We have also some syndromic forms of diabetes. I'm not going to go into that, but when you do the genetic study, what you thought was type 1 diabetes may actually turn out to be Walcott-Robinson syndrome or Wolfram syndrome or maternally inherited diabetes deafness, MID, and so on. Each one has a different prognosis, different treatment, and therefore genetic testing should be done whenever necessary. This is our registry showing you that we now have 1,562 cases referred to our monogenic diabetes registry of India, and the largest number, of course, is MODI, but neonatal diabetes, syndromic forms of diabetes, and even congenital hypoglycemia, getting low sugar just after birth, that is also a genetic syndrome. We at MDRF Chennai are a nodal center for monogenic diabetes in India, and you can see from virtually every state now, we have started getting blood samples for genetic testing for monogenic diabetes. We also have a registry. It's called www.monogenicdiabetes.in, and any of you who have such blood samples, you can send it to us. So in conclusion, ladies and gentlemen, I'd like to tell you that precision diabetes is now slowly coming of age. It can be applied to all forms of diabetes. With respect to type 2 diabetes, I told you that 4 subtypes are seen in Indians. 2 are the same as Scandinavian cluster, the severe insulin deficient variety and the mild age-related variety. 2 are unique, the insulin resistant obese diabetic and the combined insulin resistant and deficient variety. These clusters have now been replicated in South Asians in the UK also. Study of monogenic forms of diabetes may help children with neonatal diabetes and youth with MODI to go off insulin. And precision diagnosis is today possible in India, and it helps us to offer precision treatment and thereby improve the quality of life. All children with diabetes diagnosed before 6 months of age must undergo genetic testing. And if you have neonatal diabetes with ABCC8 or KCNJ11 mutation, you can completely stop the insulin and change them to sulfonylurea, which is a miracle for the child and the family. And I'd like to end by thanking my genetics team, the genomics team at MDRF, led by Dr. Radha Venkatesan, who's here in the middle, and her entire team. This department alone has 139 publications on genomics of diabetes, and 15 PhDs have come out from this department. And with that, I would like to once again thank Dr. Banshi Sabu and the organizers of this very important meeting. And thank you for allowing me to present in this conference. Wishing you all the very best.